Hello and welcome to today's episode of the Operationalizing Cell Therapy Podcast. Today, I'm joined with Claudia. Claudia, you've been in this space since close to the beginning. Welcome to the show.
Thank you. Thank you for having me. Looking forward to this conversation, actually.
Great. Right off the bat, Claudia, I'd love to sort of get your perspective. Where are we at in this industry, and what are some of the sort of current operational challenges that are holding back patients from really getting access?
It's a very good question because we've been working for the last 20 years creating amazing therapies, trying to cure very difficult diseases. We understand now how to manufacturing them, as I was saying, and we have many of the tools needed to make it happen. But for some reason, we are not reaching out. And I think that there are a couple of things that are forbidding us for growing and moving forward. One of them is the decentralization and understanding what the decentralization is. It's not only the idea of being closer to the patient and not having a manufacturing facility that is big with a lot of employees, it's just to have smarter manufacturing, orchestration of things that are happening in different locations, and trust on the data. So now is not a challenge, is not on innovation, is on adoption and operations. And the operations side is to be closer to the patient. So the hospital equation needs to be solved somehow as we move along. I think that is what is happening right now. We need adoption, mainly from the medical community and hospital settings. And we also need a little bit of understanding how to implement the decentralization properly, taking care of the data mainly.
Okay, this is super interesting. So, one thing I'm curious about is, from your perspective, when we say patient access, is the current problem there just getting the patients to the actual facilities? What are the real friction points there? What is, yeah.
I think that one of the main points is that the physicians need to understand that this is a therapy like any other therapy that they offer to their patients. It needs to be natural, that the doctor says, you need to have a CAR T. The hospital setting has to be not the exception to be a cell therapy, but to be one of the many options that they may have. Nowadays, not all the hospitals offer. The doctors don't know what will happen if the patients have a reaction to the CAR T. So it becomes a little bit, they are intimidated somehow. So I think that the main problem here is somehow the adoption from the physicians and the hospital community that this is a therapeutic option, that is a real one, and exists and has all the regulatory compliance that is needed, like any other immunotherapy or pharmaceutical or radiation or chemotherapy that they may offer to their patients. The truth is that they need to be able to adopt naturally. Right now, everything is in silos. All the data is in silos. The EHRs, the electronic health records, is in a silo. Whatever testing the patient has. So how can we talk to each other and make it adoptable? That's the problem.
So it's really like an integration problem is sort of what it sounds like. Now, I've heard a few different perspectives around this challenge with doctor adoption. I'm curious, I don't know if you've spoken to many physicians about this, but I wonder if it might be from their perspective about sort of risk to, they don't want to subject their patients to something they don't fully understand. Is it more maybe like a training thing where they may not have the, experience or training? What do you see as the sort of driver there?
Well, definitely there is a training component here because if the physicians don't understand the value of that drug, because a cell therapy is considered a drug, and they don't know what the outcomes will be and what the reactions might be or so forth, they are uncomfortable. They need to feel comfortable in order to be able to proceed and offer that to a patient. It's part of a hospital maybe that needs to be done, the training for that. And I heard that many hospitals are starting to have training, CAR-T training for physicians, so they understand what, not for offering, but for understanding what the outcomes post-infusion might be, and they need to take care of several reactions, let's say, put it this way. So what is the cytokine storm? What that means if in the context of what they are giving. It's too complex for them. Imagine that these physicians were trained years ago without that knowledge and expertise. So definitely the hospital needs to keep training their personnel like any other company and create an opportunity for them to ask all the questions. Even the pharmaceutical companies that have the products train physicians in a hospital setting, not in the office setting, in a hospital setting, so they can understand what are the tools that they have at hand if something doesn't go right, for example, or what to capture as an information for their health records in order to keep moving things forward, which is extremely important. And we can talk about that, which is data.
Yeah.
Acquisition.
Okay, that is really interesting. One thing I'm curious about here is, so there's doctors, we're talking about hospitals, and there's also most doctors are in sort of an office setting. We talked about those. Where are there a lot of differences in terms of this this education need between them? Is it what is sort of the future direction here? Is it bringing doctors to hospitals to provide their training there? Is that the way forward?
Well, and just to be clear, it's not that the doctors will be by not manufacturing the product. They will just be indicating, maybe infusing those cells and understanding what happened post-infusion, or perhaps understanding if the patient qualifies for this particular therapy instead of the traditional radiation chemo or immunotherapy that they may offer at the moment. So the truth is they need to understand what is the value and what are the indications where they can offer this as another opportunity for those patients to save their lives or to live longer and better. And on the same token, they need to learn what the post-infusion looks like and how you follow up that patient over a period of time. Those are the areas where physicians must have education and training. And I believe that the training has to come from the hospital because most of physicians are affiliated one way or the other to a hospital. That's the truth of the matter. Maybe a few not, and those perhaps through their associations should have a training where they give credits and so forth to be able to understand that this is important, or in their renewal of their licenses to be sure that this unit is being added to their exams of accreditation. So those are the things that must happen at the physician level. Some things have to happen at the hospital level. And in between all of it has to have an orchestration of the data and digital infrastructure. That's what I believe. And that's why I put a lot of emphasis right now in the career. I work a lot on the tools and technologies needed to manufacture. Now I understand that for adoption, there are other needs, and that is on the digital side.
Yeah, that makes a lot of sense. So two things come to mind. One of them is love to sort of get into if there are current sort of frictions on the data side between the hospitals. Yeah, it would be great to get into a little bit of where the friction really is in terms of the data movement, who is not getting access to the information they need. And another potential direction is around the access. So for doctors, we're talking about training, through a hospital. And I wonder, is that the same regardless of whether they're in a major city like Boston or San Francisco or in like a smaller town?
I will take the last part first. The training, because makes sense because of the conversation that we've been having. The training happens in smaller hospitals too. It's not only the big academic centers. I will not say the community hospitals, isolated ones, but what we are seeing more and more is that those small hospitals are being part of a larger conglomerate of hospitals because of savings, because of reimbursements, you name it, why they decided to create an umbrella and the reasons behind it. But the truth is, less and less you're seeing just isolated hospitals here and there, and mostly even not large, but medium, small size hospitals that have an EHR systems and so forth. They are in a condition right now to be training. Nowadays, when I started in cell therapy, talking about stem cells, God forbid, talking about stem cells, we always related to embryonic and was a little bit of a lot of ethical and legal issues around it. Today is mainstream. Everybody knows what stem cells are and what is. Well, the same happened with the therapies. Many are already approved. Many are FDA approved. So there is a more common understanding that these are therapeutic options. Need a little bit of more a massive education to understand that this is going to be part of your portfolio or menu of options as a patient in oncology, in autoimmune, you name it, the umbrella of diseases that it can be part of. In terms of privacy, data lives in silos because the truth is you cannot share patient data, and you cannot, and many companies, if I go a little bit more upstream on the manufacturing side, companies don't share data openly. So everybody is in a different silo. If the infrastructure were comfortable enough for them to feel that blind data will create value and constantly you can improve that product live on a live manner, it's going to be an amazing asset for all of us. But it's still, it's a debate. I've been working on this AI and data sharing in different conferences, in different talks, and it's incredible how hard it is for people to share data. But small groups are starting to, there are some registries, we call them, where data can be shared comfortably, but it's not massive, it's still small. And the truth is, we can only take advantage of AI if that data is significantly bigger and more diverse. And so there is so much that AI is a powerful tool can do for cell therapy because it's only as good as where in the system where the data sits in. You know what I mean? So if you don't have much data, how much AI can provide to you? And that's why I think that those are the challenges that we see. And that's why I said it's operational, because you know how to make them. How about sharing the data? How the post-infusion was for patient A, because the cells from that patient are different from patient B. So those type of things can create an extremely valuable data set that can improve the product over and over, and you can have iterations of better products for patients.
Okay. And so it sounds like with like patient data, you cannot openly share it, but there is a way where you can blind it, which means you cannot necessarily see who's the names, et cetera, the specific patient information about that. And so it sounds like there's small groups that are starting to sort of put this together. Is getting that sort of cleaned, blinded data from the original data, is that a current challenge? Is that trivial, or does that take a lot of work and sort of people hours?
No, I think that is not man hours at this point in time. Once the data is organized, clean, because you have a lot of noise sometimes that doesn't make sense to have. So there is a cleaning of the data, perhaps having a standardization in terms of data and having data harmonization would be great, but can be a little bit ahead and doesn't need to be right now. At the moment, the most important thing is to be able to share blind data or in a way, and because each place may manufacture differently, may use a different technology, may use a different set of components, so sometimes those differences are important. And that's why the data of these differences is important, because then you can create more value on the AI output can bring to you. The truth is, acquiring the data is the most important problem right now.
Mm-hmm.
Once you have the data, cleaning up the data and putting the data together so algorithms can fish whatever you're looking for, it's something that is not complicated. It's just a matter of sitting down and doing it. But the first part, the upstream part, is the one that still is a challenge. Just small groups can perhaps share the data between them, is not something universal at the moment.
Okay. And love to get a bit more into that, like that friction point there. Is a lot of it sort of resistance from the hospitals? Who is really the steward of that, the original data that is not like that has not been blinded yet? What makes it difficult? It'd be great to understand the sort of perspectives of the various people here that are part of the system and how they're impacted by this.
I think that the owners of the product, and I'm talking about products already perhaps approved, that the owners of those products have data that has to do with the manufacturing, with the acquisitions of the cells, or for the patient, how you call it, the patient, patient acquisition. At the end of the day is, it's eligible or not for this therapy. That data is sitting in different places. The patient is in a hospital with physicians that collect in an EHR system. Somehow that doctor perhaps can say, okay, you, because it's connected with different pharma companies, will say, you are eligible for this therapy. They connect with the pharmaceutical company may manufacture, and it's one way of doing it. The manufacturing facility, CDMO, whatever, they manufacture, and once the cells were collected from the hospital, were shipped, the pharmaceutical then becomes a black box. Pharmaceutical companies manufacture, release, and then send back to the hospital. And the hospital has another set of data. Well, I received the cells, I infused the cells, and I have post-infusion data. So the data is fragmented.
Right.
It's not in one place and not one only owner of it. It's fragmented and several owners of it. That's why you need to create consortia, a registry, where that data legally bound all the members of that registry that can create a comfortable setting for them to sharing that. But each one of them have a data set that they own. And so when we talk about decentralization and we say, well, what about manufacturing close to the patient? Then you take that part of manufacturing that sometimes happen in a pharmaceutical setting or CDMO close to the patient, where the patient already have an EHR with all the data. So you're bringing all that proximity also on the data as well, you know what I mean? Which I think that will create value at the end of the day. So the decentralization is a little bit of a weird word. A lot of people talk about decentralization only about the CDMO, the manufacturing, but it's beyond that. Decentralization means the therapies are closer to the patient. For investors, even maybe is a different, instead of investing in larger manufacturing settings, in systems, perhaps. So it's a different equation as we move along, and the decentralization becomes a bigger word, not only manufacturing.
It sounds like one of the sort of key data handoff friction points there is between manufacturing, like the CDMO, and the hospital.
On another interesting topic, which is reimbursement.
Yeah.
And the payers, the more data the payers have, the more then they can justify the payment of that drug.
Yeah, well, that would be a great sort of next direction is, about that sort of payment dynamic and where the current friction points might be in that regard. One thing that's come up is a significant challenge for smaller hospitals, like in rural settings, who might be sort of sitting on a bill for, if it's $3 million or what may be that could be like a really, really significant challenge for these smaller hospitals. Yeah, what is your take on this?
Well, usually you work with prior authorization for these therapies in general. You don't infuse without knowing that it is someone at the end, on the other end, to catch the bill. But in general, I think that, therapies are becoming a little bit cheaper. I would not say that they are cheap, but they are less expensive than they used to be at the very beginning. And we need to make a big separation on gene therapy and gene editing, on cell therapy and autologous cell therapy as well, and allogeneic eventually at one point, although they're not approved yet. So there are a lot of different nuances that is not that straightforward answer to that. But the idea is to create a scale out big enough for the cost to go down and justify through the payers that this is a therapy that if you take the economics on long-term treatments and so forth, it makes some sense for some particular patients. Payers have been on the table in conversations for the last few years. And now we need to that's why I said the challenge right now is operational. Bring the patient, bring the hospital, the manufacturing closer to the patient, and the payer, everybody sitting on the same table. That is what the future should look like.
Yeah, that's really coming back to the sort of integration we were discussing. It sounds like it's a very complicated communication problem getting all of this to sort of work together.
The complication is because there's a lot of interest, and definitely, I think that if people can find a way to share the data and take advantage of that, because you can create a better product, because you can have more patients and more adoption of those therapies because the data is being shared and more information is available, I think that it will be a common sense to do it and create the instruments, the legal instruments to be able to share the data will be incredibly amazing. And use all these amazing tools of AI and so forth that we have today, can create so many incredible, not only drugs, but interaction with many drugs at the same time that could be, we want to live longer and better, not only longer.
Yeah. Well, as we're sort of getting towards the end, I'd love to sort of hear about your future outlook. We've talked about decentralizing these existing technologies and sort of how might that affect both from the patient standpoint and the investor standpoint, like looking forward in comparison to where we are now.
Well, it's what I said at the beginning. Patients are looking to be closer to where the manufacturing is happening. And that's why I think needs to be hospital, community hospital, or centers that are close to a hospital setting. So they are close to the center of treatment. They don't need to travel. They don't need to create this medical tourism and what have you, closer to the patient. And for investors, the truth is they've been investing in different areas for the last few years. Innovation, CDMOs as infrastructure of manufacturing, and more we are seeing a little bit of more platforms in terms of automation of manufacturing. I think that the direction is coming there. Now it's about data. It's about creating the digital infrastructure to orchestrate all this. And I think that we are on that path, at least I am.
Amazing. Thank you so much for joining us today, Claudia.
No, thank you. Thank you for the opportunity. Looking forward to see all this happening in the near future.